I was kind of thinking when I came into this room earlier that there's some great quotes on your boards and your advertisements here. And I was looking through my collection of quotes, because I like quotes. And it's one from Davos earlier this year. You know, Davos was where all the leaders from Europe etc. went, and they talk about the economy and the important things happening in the world. But this year, they actually spoke about data and big data as well, so they got it right this year. And there's a great quote that came, and it was, "Data, when collected and analysed correctly, tells you the truth. The truth about your environment, the air you breathe, the water you drink, the truth about your body, your weight, the health of your heart, the truth about your diet, nutritional value of the food you eat, and the impact your choices make on your personal health." Perhaps not so good after lunch. But with truth comes the ability to understand, to take control, and to change. And I guess that really nicely sums up why we're all here, isn't it? It's about using that data to generate information, to have an information-driven healthcare. I've been asked to speak specifically about big data in Scotland, and I'll come on to talking about the Stratified Medicine Innovation Scotland Centre. But first, before I go on to talk about that, I thought I'd tell you a little bit about Aridhia. Chris said we've got about 85 people. We're a mix of data scientists, IG people, we've got software engineers, we've got computer scientists. We've also got, crucially, clinicians. And I think that makes us quite different from other companies. We not only employ our own clinicians directly, we've also got researchers, and we've got a clinical faculty linked to the University of Dundee. Our link to Dundee goes back to Professor Andrew Morris, who I think Liz touched on and Chris has mentioned as well. And Professor Morris and David Sibbald are our co-funders. And Professor Morris has got huge wealth and experience in diabetes, as you've heard about. But he also had some great ideas. And he thought, wouldn't it be great if I could commercialise some of these ideas and we could take them out to the wider NHS? And that was why he and David established Aridhia about 6 years ago. We're not your normal company, as I've said. We've also got NHS Scotland as one of our shareholders. And we very much have adopted a collaborative approach from the beginning. Collaboration in terms of the structure of the company, but also the way in which we work. To date, we operate globally. Apologies, this is meant to be a map of the world. It doesn't really work, but on this screen. Down the bottom, we've got Australia, and we've got a number of projects ongoing in Australia. These are just a few of our projects. And in Australia, we've got some cancer projects. So we've got a couple of examples where we've got some of the territories are using some of our cancer informatics services. One of them is actually using patient-reported outcomes in terms of chemotherapy prescribing. As you can see from this, we specialise in chronic diseases, and the two areas in particular are cancer and diabetes. On diabetes, you've heard a little bit about Kuwait, but we also work across other parts of the Middle East. We actually supply a diabetes system to the Ministry of Health in Kuwait, and it's the largest system in use across Kuwait, and it's currently being rolled out across Kuwait City as we speak. Kuwait's an unusual example. We went in and we provided them with our first clinical information for diabetes. I'll show you some of the outputs from that later, but we provided clinicians with access to not only primary care, but secondary care information. And they use that data to provide information for face-to-face consultations, to generate reports, for auditing. So really, it's their BI tool, and it's actually their clinical tool as well in the clinics. Closer to home, we've just completed a 2-year project called Decipher. Decipher was a large cancer informatics project funded by the Technology Strategy Board. We worked collaboratively, that word again, with 2 trusts in Scotland, NHS Lothian and NHS Tayside. And we worked with the respective universities of Dundee and Edinburgh. And the purpose of that TSB-sponsored work was create 2 things. It was to create some clinical analytics services for cancer, and it was also to create some research analytics. So again, it was all about making that sort of translational medicine real. That project concluded at the end of 2013, and it's from Decipher that we now have our analytics product, an analytics service that I'm going to talk a little bit more about. And the other thing that we currently do in Scotland is we have quite a number of NHS clients, and the NHS trusts in Scotland are deploying risk stratification services, and they're also doing things like patient tracking, 18 weeks. So the kind of informatics tools based on a mix of primary care GP data and information coming from their patient management systems and patient administration systems. So there's a range of service and products we're currently deploying, all of them in chronic disease management, predominantly diabetes and cancer. And crucially, it's about bioinformatics and analytics and ever increasingly stratified medicine. For us, open and comprehensive collaboration is key. Not just collaboration where people say, oh yes, we're working on that project, we're all collaborating, but actually active collaboration. It's got to be genuine. If it's not genuine, then our projects and our work is not successful. Key to our success, when you look at our projects in the past and our ongoing collaborations, is this open and comprehensive collaboration. Open, we're very transparent as a company. Comprehensive in terms of our partners. We've got partners across academia, healthcare providers, payers, industry, and crucially patients. We have EMC Pivotal as one of our key industry partners, but we actually have links to lots of other smaller companies. And I think that's vitally important, not just for a relatively small SME like Aridhia, but for all companies as we go forward. Our model, as you've sort of heard so far, is different, but we believe it reflects the needs of modern day health challenges and the future health challenges. And I think what makes our model work, and particularly relevant for the people in this room, is that it's grounded, it's got information governance at its core. So a little bit about the Stratified Medicine Innovation Centre. It's a bit of a mouthful, so I tend to refer to it as the SMSIC. It's a new approach to collaboration, and it's not the only big innovation centre in Scotland. It's actually one of 4. There are 2 others currently sort of being developed, one in digital health and one in M-health and sort of medtech. But this is the innovation centre that Aridhia is very involved in. We were actually key to its development. David Sibbald, our chief executive, was in from the very, very outset, along with Professor Morris. And it's got 3 main types of partner. It's got technology partners, of which Aridhia is one of 2 main technology partners. We provide the technology platform, our analytics platform, the same platform that came out of the Decipher project that was TSB funded. And that's the platform which originally was intended to be for research, but increasingly, as Chris has mentioned, Aridhia will use it to deploy our clinical solutions into that environment. And that platform is being user tested and accredited as we speak. So it's in place, all the technology is there, the big boxes are in place, or the not so big boxes possibly now, Chris. Our support team is doing the final testing, and 2 exemplar projects are ready to commence around about the 1st of April. And alongside us, we have our partner is Life Technology, who are one of the leading providers of genome sequencing. And so you've kind of gathered by the name and also by the fact that there's Aridhia and Life Technologies that this is all about stratified medicine. This is all about speeding up the translational research cycle. Alongside Aridhia and Life, we have the NHS, and the final partner is academia. We have a collaboration with all the main universities in Scotland, and crucially the universities that have medical schools attached to them. So it's difficult, I guess, to underestimate just how challenging this is. What we've done in this model is we've brought together the whole of the NHS. Now I know there perhaps aren't as many parts and it's a little bit more joined up perhaps than in England, but we still have 14 trusts or boards in Scotland with their own governance, with their own Caldicot guardians, with their own chief executives and finance departments, but we've brought them all together. We've got the leading universities in Scotland. So there's competition between them, you know. So it's not an easy task to bring them under one roof, to get them round the table at the same time, to talk, to agree. Even to agree a budget can be challenging, but we've done that, thanks to Professor Morris and David Sibbald. And this facility will be live as of April this year, and will be a core facility in Scotland for sequencing at scale and for translational medicine. The plan is, and I guess this also makes it quite revolutionary, is that this centre will be co-located in a new hospital that's under construction in Glasgow. I'm not sure if we should be proud of this, but Glasgow are building one of the biggest hospitals in Europe. A vast number of hospital beds, which I know isn't the done thing these days, but you know, Glasgow has its health problems. But part of that new complex will have a whole floor in the hospital, and that's where the Stratified Medicine Innovation Scotland Centre will be co-located. So we'll actually move our people, our office, into that facility, as will Life Technologies. They'll move their facility in there too. So we'll actually have a building with patients on one floor, wards on another, all the clinicians, the researchers, and the industry partners in one building. You know, I think that's quite revolutionary for the health service in this country. Quite a different model. So this is going to be my only technical slide. This is about as technical as I get. And this is a schematic of what that platform looks like. I've talked about the Aridhia platform. And this shows the flow of data into that platform. And you can see at the bottom, we've got very small letters at the bottom. We've got clinical systems, we've got academic systems. And the whole point of this platform is it's a collaborative platform. It allows people to take their data into it and to collaborate across institutions, across boundaries, across countries. In fact, Liz talked about Horizon 2020. We're also talking to people about Horizon 2020, and they see this platform as being a way of working across numerous EU states, because it doesn't sit in any particular country or organisation's stack. It's our commercial platform will be web-based, will be web-hosted, it'll be a hosted service, which will allow people to go in and to input their data, to share their data and to share their findings in that secure environment. But in terms of this platform, it's located in SMSIC. The different colours show the different intellectual property where that resides. So you see we've got the Aridhia platform here, the big box. That's the core Stratified Medicine IC infrastructure. And it's within which Life Technologies are operating. We've got the genetic data coming out, and then we've got the enhanced services, the additional services Aridhia offers, and then our customers and the other SMEs towards the top. Like Manchester, somebody mentioned the Manchester ecosystem. What makes the SMSIC really exciting is that around it we've got a whole ecosystem of SMEs, biomedical, research companies, and other organisations working with us and our partners. I've talked a lot about collaboration, about sharing data, and I've also said that core to what we do is information governance. I think we saw her pictured earlier, but we've got an IG practitioner. We've probably got one of the best IG practitioners in Scotland, if not in England perhaps, working for us. I can say that I used to work with Kim in the Scottish Government, and because of that, we've been able to develop our system, our platform, with IG at its heart. The diagram you've got here shows the kind of flow of data through our system from left to right. Crucially, data owners retain control of their data at all times. It allows third-party role, trusted third-party role to be supported, and that's important for us as a company. Our model's all about self-service analytics, but as Aridhia, we have a data science laboratory. So if the people coming to our platform don't have the skills, we can actually help them. Then we can deploy models, we can deploy scripts into the platform, and we can help accelerate learning in organisations, hence the need for that trusted third-party role. We assume that the data, will be de-identified at source, and we can assist in that de-identification of data too. Our platform allows you to, as I said, to upload data into. It also gives you the facility to have a number of workspaces, and as I've said, a number of users within that environment. You can really have as many workspaces as you want, and as many users as you want. And it grows with you as your data needs grow too. So you can start up off small, and as your data requirements get greater, then so too can your use of the system. There's no need to invest in a huge amount of infrastructure, well, any infrastructure up front. Once you've finished your work, you can export your results. You can take all the models you've produced, all the scripts you've produced, and take them with you. Your data can be removed, your data can be destroyed, or your data can be reused, reanalysed, used for a different purpose. I think also what's quite important is we can take different types of data. We can take structured data, unstructured data. You can, in the case of diabetes, we take data to do with deprivation. In the case of cancer, we look at information on mortality. So you can take a variety of different types of data and combine that within the research platform. I'm going to keep saying it, but it's collaborative, obviously, it's hosted, and it's an iterative process. The first phase is to upload your data. Well, sorry, before you go to that first phase, it's about having a data sharing agreement in place. Second phase is you upload your data. The third phase is to perform your analysis. And what makes the Aridhia platform quite unique is it has lots of inbuilt tools. So if you come to the platform, you'll find Hadoop and R and Madlib, etc. already in place. You don't need to have the licenses to actually operate these. They're all built into the platform. And as I've said, if the people in the organisation don't have the skills, we have a team of data scientists in the laboratory who have those skills. They can assist you in that. And they can pre-populate your workspace with models and scripts that you can run. Phase 4, we call that export for speed to value. It's a really fast process. You know, we've got Hadoop in there. We can use the platform to generate value incredibly quickly. It's all about that speed. It's all about moving quickly, moving rapidly, driving the most value out of your data as quickly as possible. We've got a phase we've called wrap up. And after you've produced your value, you can decide that's the only use you've got of your data. So it's time just to move on. Or you can reuse your data sets, you can share your workings, and you can reuse. It really is entirely up to the user. After all, you know, the data owner is the data controller. I should say actually, in terms of exporting and speed, a good example of that is that if you're a researcher using the platform, you can actually publish your papers in that space. We've pre-populated it with templates. So if you know the template you want to publish into, let's say it's going to be the British Medical Journal or whatever, you can just press that template and out comes your research in the correct template. And perhaps an hour later you can run it off for another scientific journal. So we've made life very easy for researchers and clinicians to collaborate in that joint space. It's fully auditable. You can track who's had access to the data, when they had access to the data, what use they made of the data. And obviously it's a bit like most of the software you're using in clinical systems. You can give permissions as to who sees what, when they see it. So it's fully controllable. You decide who sees what, when, how much they see. And finally, as I've said, the information can be reused, recycled, or it can be removed and destroyed. Okay, so nearly there. I guess there's a few principles that we really, really believe in. And the first that Chris has touched on is it's about outcomes. It's not about buying infrastructure anymore. That's not the new model. That's not the model that's going to help us tackle some of the huge challenges facing healthcare, not just in this country but beyond. It's about driving benefit out of your data. It's about creating an information-driven healthcare system. And at its core is information governance and information security. Our whole operating model, as Chris touched on, is self-service. And we also believe that if we're going to be effective, make most value, efficiency, then we have to operate in the cloud. So our platform will actually be launched in about 4 weeks' time, our commercial platform that I've talked about. And that'll be available in the cloud, both in the N3 and the non-N3 environment. And it's a self-service model. The platform allows you to collaborate at scale, and to upload structured and non-structured data, and to undertake rapid analytics and advanced analytics and bioinformatics. I've said before, we're using some of the most powerful bioinformatics analytics tools out there. And we believe that we've got the potential to speed up that translational cycle and deliver value back into healthcare. And just finally, here are some examples of what we're currently doing. And I could have put a lot more up here. I haven't got the work we're doing with Genomics England, some of the imaging work we're doing for Genomics. What I've got here is on the left, you'll see some of the work we're doing in diabetes. Diabetes is one of our priority areas of work. Our founder, Professor Andrew Morris, has achieved some tremendous results through his use of analytics. Liz referred to some achievements in diabetes. I think he found that he could reduce the amputation rate by about 40% through analytics and through bioinformatics. That same technology that he initially used in Dundee almost 10 years ago now, we're using in Kuwait and elsewhere. And what we've done through that is, and through our work with our clients, is we've now developed a diabetes bundle of metrics. And those images you can see are some of those images that the clinician gets. Currently in diabetes, the clinician will get maybe an annual audit of his results based on the last year. Now that's all very interesting from an audit purpose, but it doesn't really help that individual to make decisions. It doesn't really help face-to-face care. What these images you'll see here give the clinician is they give them near real-time information. The clinician can run these scripts on a weekly, fortnightly, monthly basis, and they can actually use these to inform patient care, whether that be information on who's on their medication levels, or it could be to do with weight, or it could be to do with key indicators. I think that one there is to do with, I'm not sure what that one to do with, but they also can do risk stratification. They can look at foot scores, they can look at eye screening. It's really up to the individual, but it allows clinicians to take real decisions based on near real-time information. The top image you see there is work we do on preventing readmission to hospital. We do a number of, we employ a number of risk stratification models. The one up there is PAR 30, and that's about readmission within 30 days. It was developed by Nuffield, and we've taken that model and we've deployed it into our research analytics platform. It's part of a two-stage process. The first process is looking at the quality of the data, looking at the completeness of the data, and the second bit allows the clinician or the team to run the model and look at the risk of a patient on discharge being readmitted to the hospital within 30 days. That's of interest to, I'm sure, lots of people in this room, as it is to many in the NHS in England. But we do other models too. We also do risk stratification within primary care. Some of the models we use in Scotland are Sparrow, Peony 2. which are all about looking at the risk of readmission and looking at vulnerable older patients and helping the GPs put in place care packages preventing admission to hospital. And finally, at the bottom there, we've got some of the work that we did in association with Decipher. Decipher looked at a number of cancer types, including breast cancer and ovarian cancer. It developed a number of metrics, and included in that was survivability. And again, all of this can be done in near real time. It really depends on the completeness of your data and how frequent your data is uploaded into the platform. In all these examples, we're taking nightly feeds. So the individual clinician can update their report on a kind of daily basis. In practice, we see these tools being used about weekly.